Hi everyone, this is Professor Rivera-Mitu, and in today's video we will be discussing the antihypertensive medications, with a few of them affecting the renin-angiotensin aldosterone system. So today we will be talking about antihypertensives. In a previous video that I have posted, I had discussed the renin-angiotensin aldosterone system and the physiology of that, and how basically blood pressure is increased due to the effect of the RAS. So today I will correlate the RAS with the medications that we use for hypertension. So before I go over that, kind of want to add this little bit about blood pressure just to define what blood pressure is. So blood pressure is basically your cardiac output times your peripheral vascular resistance. That's how we measure that. And if we're talking about cardiac output, technically speaking, cardiac output is your stroke volume, right? Stroke volume times your heart rate. And so the factors that affect blood pressure with regard to cardiac output, one is the contractility of the heart. The other is the heart rate. How fast is the heart beating? And then the other thing that we are concerned about is preload. So preload is basically that pressure that the ventricles feel at the end of the diastole. So when the blood is being dumped, if you will, into that ventricle from the atrium, if there's a lot of volume, then the preload is increased. So I kind of want to think of this as if you're under a waterfall, how heavy that feels. So that's kind of like what preload is. And so that affects your cardiac output, and that also affects the pressure that the ventricles feel. And eventually, in heart failure, this is one of the goals, is to decrease the preload so that the blood pressure will also decrease and the work of the heart will also decrease. So the other part of that is peripheral vascular resistance, or PVR. And this is driven by the vasoconstriction of either the arteries or the veins. So the constriction of the arteries is multifactorial, and definitely the CNS has something to do with both of these. So the central nervous system will trigger the heart, or can trigger the heart, and at the same time, it can also cause vasoconstriction when triggered. And a CNS, particularly also your the sympathetic nervous system, your SNS. Another name for sympathetic is adrenergic. And we need to remember that as we talk about the medications that affect blood pressure. Just to kind of add that to that too, it's important for us to know that stress triggers the sympathetic nervous system. And this could be through physical stress, which is through, if someone is ill, any acute illness can cause physical stress, or even just someone who is not able to get enough time of rest. Maybe they've been working too much with inadequate rest time. That is can cause physical stress. Or it could be emotional stress as well. Especially, during COVID, there was a lot of emotional stress that had happened. So that can affect the sympathetic or adrenergic nervous system. And in addition to that, any other factor that affects the CNS, stimulants can affect the CNS. That could trigger increase in heart rate or vasoconstriction. So that affects blood pressure, and as previously discussed, that also can decrease the perfusion to the kidneys, which can trigger RAS. So what I have here on the side are the different classes of antihypertensives, and some of them directly act on the RAS and some act outside of the RAS system. So what I'm going to do is kind of place them where they belong, so that you guys can, understand better the mechanism of action, and where they act. So if we look back at this RAS, we can see here that after the release of angiotensinogen from the liver, renin is necessary, which is released by the kidneys. Renin is necessary in converting that to angiotensin 1. So if a drug such as the direct renin antagonist is given, then that antagonizes the effect of renin. And so that kind of nips this whole thing in the bud. Right? So renin acts there, which would have been good. The only problem is the direct renin antagonist, because it acts in the kidneys, has been known to actually trigger kidney failure or chronic kidney disease. And so because of that side effect, then it's not prescribed as much. And there's only one direct renin inhibitor in the market at this time, which is eliskerin. That's the name of the drug. So if we're not able to stop this whole pathway here by stopping renin, then the next best thing is to stop the conversion of angiotensin 1 to angiotensin 2. And so, of course, that is where ACE inhibitors play a part. And ACE inhibitors, ACE angiotensin converting enzyme, as I mentioned, stops the conversion of angiotensin 1 to angiotensin 2. So one thing to remember about ACE inhibitors, however, oops, I think I deleted it by accident, is that the way that it actually works is it works by stopping the conversion of angiotensin 1 to angiotensin 2, and that happens in the lungs. So because it happens in the lungs, a side effect of ACE is dry cough. And ACE, they end with prils, such as captopril, lisinopril, ramipril, and any other prils. So that is a first go-to drug. Usually, let me try and fix this. Usually, because direct renin inhibitors have fallen out of favor. However, because of the side effect of cough, not a lot of people are able to utilize it, especially in Asians and Caucasians. There has been more of the cough, and so Sometimes if that's not possible, then we go to the second best thing, which is a drug that blocks the effect of angiotensin 2. And that is your angiotensin receptor blockers. So I call it the ARB-sartan. So because the ARBs end in sartan. So just like the examples that I have put on here. So let's place this where this belongs, which is right here. Examples of ARBs are candesartan, losartan, valsartan. So those are your sartans. So they stop the receptors from basically doing all of those things and down here. They stop all that. Part of RAS is also the increase in blood volume because of the reabsorption of sodium and water. And in general, again, with the increase in fluid, that increases the cardiac output, and that could cause increased blood pressure. So one of the medications that we give are diuretics. Actually, before I go into diuretics, forgot about this one. It's also a diuretic, but technically speaking, the potassium-sparing diuretic is under the aldosterone antagonist category. So the aldosterone antagonists or aldosterone inhibitors, they inhibit aldosterone from being released. So let's find where aldosterone is at in our map. Okay. I believe I have it somewhere here. There it is. So this is where that works. So the aldosterone antagonist basically works in the adrenal cortex, and it works there to stop the release of aldosterone. So therefore, if aldosterone release is stopped, then the kidney is able to release the sodium and also able to save the potassium. And which is why it's known as a potassium-sparing diuretic. Now, however, some important side effects or other effects of the aldosterone inhibitor can be remembered by thinking that this is, again, something that acts in the adrenal cortex. So because it acts in the adrenal cortex, it also technically inadvertently causes androgen inhibition. And androgen is a secondary male hormone. And so if a male patient takes spironolactone consistently for the control of blood pressure, because of the inhibition of androgen, then the patient can get gynecomastia or development of breasts in male. Now, conversely, spironolactone, because of its androgen inhibition action, is also indicated for acne in females. And it's also used as a medication in male to female transgenders because of the androgen inhibition and the gynecomastia. And of course, in those cases, these become the desired mechanism of action. And then the diuresis and hyperkalemia becomes the side effects. So I'm just going to put that there. If you're wondering why acne, testosterone causes acne. And so when we give a spironolactone, which is because of the androgen inhibition action, it decreases acne, especially in females. So acne and male to female transition. Okay. Now, the other medications that's listed here, going back to the diuretics. So these are the different diuretics that are used in hypertension. So we have the thiazides, the thiazide-like, and the loop diuretics. So if we plug that in here, they actually can be plugged in a couple of different areas. So I'm just going to put them down here. And then I'm going to copy that and we will put it somewhere else. So, and I'm putting it here because diuretics decrease preload. And so when we decrease the preload, it decreases the blood pressure because of the decreased volume, the decreased cardiac output. And it also causes less strain to the heart, so that in essence, you're helping a patient who has perhaps heart failure. And here's the other place where we can put that, because it does act in the kidneys to excrete the extra fluid. So then it helps decrease blood volume. It may be of important note to look at the side effects of some of these drugs, however. So thiazides work in the distal tubule of the nephron, and so they actually inhibit sodium and chloride reabsorption, thiazides do. So when we're talking about electrolyte imbalance due to these medications, so with thiazides, we first think of hypokalemia as the main side effect. Let me fix that real quick. Okay, so sorry, hyponatremia. Because it's inhibiting the reabsorption of sodium and chloride. As opposed to loop diuretic, it mainly affects potassium reabsorption. And so with loops, we're more concerned about potassium loss. With thiazides, we're more concerned about sodium loss. Now, that's not to say that we're not going to be concerned about the other electrolytes, but mainly if you're thinking of the first electrolyte that is affected, then thiazide sodium, loop is potassium. Now, keep in mind also that sodium imbalances affects the CNS first. And so one of the first sign of a sodium imbalance, and this is true whether it's a hyponatremia or hypernatremia, is headaches, irritability, even hallucination, because it's all CNS related. Okay, so the first system that is affected is the CNS with a hypo or hypernatremia. So when you see that, when a patient's complaining of a lot of headaches, or they're beginning to like see things, or they're lethargic, check the sodium if they're taking a thiazide. Now with the hypokalemia, generalized weakness might be an issue, but more importantly, when they're taking a loop diuretic, typically this is also given to patients who may have congestive heart failure. And those congestive heart failure patients may also be taking a inotrope medication to increase the contractility of the heart. It is important to know that if they are taking an inotropic such as digoxin, and they are in a loop diuretic, that the potassium needs to be monitored, or the patient would need to be on a potassium supplement, because if potassium is low and there's digoxin in the system, it could cause digoxin toxicity. So it's very important to monitor potassium in the patient who's taking a loop diuretic and digoxin at the same time. Now, the other medications that we have here are the adrenal receptor antagonists. So adrenal receptor, which is your adrenal gland, and adrenaline, which is your synonymous with your sympathetic, adrenergic, sympathetic nervous system. So there are technically 3 classes of your adrenal receptor antagonist drugs. We are familiar with the beta blockers. So the beta blockers, I call them the beta-lols. So the beta-lols obviously block the beta receptors. And these are examples of the medications: atenolol, metoprolol, propranolol, carvedilol. It is of note that propranolol is a non-selective beta blocker, which means it doesn't just work in the blood vessels, it actually works more systemically. It is used in a low dose in anxiety, especially test-taking anxiety, or generalized anxiety disorder, and it could cause lethargy because of its systemic effect. And before I move on to the alpha blockers, it's also important to note that labetalol is up here. So labetalol, even though it ends in lol and it is categorized as a beta blocker, it also has alpha blocker properties. And typically, labetalol is indicated, and by the way, this is also a non-selective beta blocker. As we mentioned, it's both beta and alpha blocker. Typically, labetalol is used in OB, in preeclampsia. And then we have our alpha blockers. So doxazosin and tamsulosin, so your SINs, are drugs that are also used for benign prostatic hyperplasia. So they have 2 uses, 2 birds in 1 stone, wherein you can use them for patients who have BPH and also have hypertension. So these drugs, because they are sympathetic or adrenoceptor antagonist, we are going to put them down here by the CNS, or the sympathetic nervous system. So put them right there. Okay. Now, because they affect the sympathetic nervous system, they technically affect the heart rate, and at the same time, they also affect the vasoconstriction, right? So beta blockers will cause vasodilation and decrease in heart rate at the same time. And so therefore, we want to make sure that we check the patient's heart rate before giving any of these beta blockers. Alpha blocker also helps with the relaxation of the vascular smooth muscle, which is what causes vasodilation. Now, CCBs, calcium channel blockers, there's a few of them. The most common ones that we see used for hypertension are the dihydropyridines. So I call them the dipines, which are your amlodipine, nifedipine, nipodipine. So CCBs are also the one of the first lines of treatment for primary hypertension in patients over the age of 55 and in Black patients who are of African or Caribbean descent. The other CCBs, such as diltiazem and verapamil, they're typically used to control dysrhythmia, so they're anti-dysrhythmia drugs. And then, of course, nifedipine is also used in anginal pain, angines. Okay, so but what they do, because they are calcium channel blockers, so they block the calcium from going into the wall of the blood vessel. And so that relaxes the vessel wall, causing vasodilation. So they actually act here, causing that relaxation. Vasodilation. It's important to note that because of the mechanism of action of CCBs, they can actually cause edema. So the edema that this causes is not just dependent edema in the lower extremities. It causes swelling of the hands or the feet, and can also cause flushing, which is due to the vasodilation and headache. So we'll put that here as the side effect. So edema due to too much vasodilation. And again, not just the feet, but hands and feet. And also flushing, which is when their face turns red, and headache due to over vasodilation. It may also cause reflex tachycardia. So this might be important to also note. So basically, it could cause the heart to increase the heart rate, which, if it's being used for angina, then it kind of becomes counterintuitive, because it could cause decreased perfusion to the myocardium due to tachycardia, and can cause more myocardial ischemia. The other CCB, so these two we will place by the heart because of their effect in the heart. There we go. So they decrease the oxygen demand. So they actually decrease contractility of the heart. And so therefore decreasing oxygen demand. Okay. And then I think we have two more. So these two cause vasodilation. So hydralazine and minoxidil are direct acting vasodilators. So they act in a couple of areas, obviously here in the, and I'm going to copy that so that we can see where else it works. So they vasodilate. So technically they also work here, right, to prevent that. And if we look back at the RAS, we'll see that angiotensin 2 is a potent arterial vasoconstrictor. So drugs such as the CCB and the other drug, which I'll mention in a minute, also can help in vasodilating due to vasodilation due to the effect of RAS. So we're going to copy that over and also place that here. Oops. There. And so the other drug that I have here, let me just put this here first. So stops that. And it's also important to note that hydralazine shouldn't be given as a maintenance antihypertensive. It's usually given for very high blood pressure, and it's typically given like in the emergency setting. Minoxidil, what's unique about this medication is that this is also used for male pattern hair loss. So it helps regrow hair in males. So if a male patient has hypertension and is balding, then minoxidil is a perfect medication for them. Now the other one is clonidine, which is also used for emergency control of blood pressure. So this is a centrally acting alpha-2 blocker. And this is a medication that works systemically. And so it affects the CNS. So because it affects the CNS, it causes lethargy. Okay, so the patient becomes drowsy as a side effect of centrally acting agents. They become lethargic due to CNS depression. Methyl-dopa is commonly indicated for pregnancy-induced hypertension, or otherwise known as gestational hypertension. That's one of the most common drugs that is administered in pregnancy for hypertension. And so there you have it. That is all of the antihypertensives in a nutshell.